I will be talking today about the renal physiology. The functions of the kidneys are to regulate extracellular fluid volume, extracellular fluid electrolytes composition, to total body water volume, body's acid-base balance, and arterial blood pressure, as well as to produce 125 dihydroxycholecalciferol, that is active form of vitamin D, renin, erythropoietin, glucose, and to excrete endogenous waste products, urea, creatinine, uric acid, bilirubin, and exogenous waste products like drugs and drug metabolites. Okay, so gross anatomy of the kidney. There are two separate kidneys. With I will just finish the little bit of anatomy, sir, in 2 minutes. Gross anatomy of the kidney. There are two separate kidneys with its own fibrous capsule. They are retroperitoneal in location in upper abdomen in each paravertebral gutter at the level of T12 to L3. Each kidney is 12 centimeter long approximately and 150 grams each. Right kidney is slightly lower than the left because of the liver. And upper part of each kidney is protected by 11th and 12th rib posteriorly. There are two distinct regions in kidney, cortex around the outer edge and the inner medulla. The medulla has numerous renal pyramids. Innermost end of the pyramids are called as calyces. They are major and minor calyces. They receive the urine, drain to the renal pelvis and ureter. This is the basic functional unit of the kidney is nephron, and each kidney has 1 to 1.5 million of nephrons. So nephron is a folded of tube which consists of proximally a complex capillary network and a capsule that is called as glomerulus and Bowman's capsule. Distally, it is collecting ducts from which urine drains. The glomerulus, Bowman's capsule, proximal convoluted tubule, the loop of Henle, and the distal tubule. All these things constitute a nephron. Glomerulus and capsule. Glomerulus and capsule is cortex, loop of Henle, collecting duct in the medulla. Anatomy of the nephron. The glomerulus and the Bowman's capsule. Every nephron has a glomerulus and all glomeruli lie in the cortex. Arrangement of specialized capillaries inside this the Bowman's capsule consists of afferent arteriole at one end and efferent arteriole at the other end. And this produces ultrafiltrate of plasma that enters the nephron tubule lumen at the Bowman's capsule. The proximal tubule is a continuation of the nephron tubule from Bowman's capsule. It has two parts, the convoluted proximal tubule, that is pars convoluta, and the straight part is pars recta. The reabsorption of it has this reabsorption of electrolytes and water lost from the plasma through the filtration at the glomerulus. It also secretes some substances into the tubule lumen like drugs. It is responsible for regulation of acid-base balance. The loop of Henle is that descends from the renal cortex into the medulla, hence descending limb, then takes tight U-turn and then ascending back towards the cortex, hence the ascending limb. Ascending limb is thin wall section. Ascending limb has thin wall section and thick wall section. The nephrons with glomeruli on very outer edge of the cortex have short loops of Henle, and the nephrons with glomeruli near the corticomedullary junction has long loops of Henle which descend deep into the medulla to the tip of the renal pyramids. This cortical nephrons almost constitute to 85% of the total nephrons, and the juxtamedullary nephrons only 15% of the total nephrons. This is a structure of juxtaglomerular nephron and the cortical nephron. Then juxtaglomerular apparatus. This is the final part of ascending limb of loop of Henle, which is located in the cortex of the kidney, that is immediately adjacent to the afferent and efferent arterioles of its own glomerulus. It consists of macula densa, which is specialized cells in the wall of the tubule at this point. They are capable of sensing and responding to the composition of the tubular fluid. The afferent arterioles has granular cells, which are specialized cells that secrete renin. Then collecting ducts. The collecting duct starts after the termination of the ascending limb of loop of the Henle, and the collecting ducts of all nephrons pass through the renal medulla to drain urine produced by nephron into the calyces. Renal circulation. The renal circulation, then a renal artery, which is direct branch of abdominal aorta, renal vein, which is drained into inferior vena cava. The renal artery, renal vein, and the ureter, the three enters at the medial side of the kidney at hilum. The right kidney is has longer renal artery, and left kidney has longer renal vein. The renal artery divides into interlobar arteries, then arcuate arteries, then interlobular arteries, which give rise to afferent arterioles. Then it forms the glomerular capillaries and ends to efferent arterioles, and then peritubular capillaries. This glomerulus is unique in capillary formation because the capillary bed both ends with the arterioles. The venous system is in the reverse. The peritubular capillaries, which drains into interlobular veins, then arcuate veins, then interlobar veins, and the renal vein. The renal plexus of the nerves, originating from T10 to T11, receives both somatic innervation and the sympathetic nervous system innervation. As we can see in the diagram, there is dividation of renal artery and the renal veins. The renal blood flow, kidney receives total blood flow approximately 1000 ml per minute, that is 20% of the cardiac output. That is 300 to 400 ml per minute per 100 grams of the tissue. It equals to 6 times that received by brain and 5 times that received by heart. This renal blood flow is not evenly distributed, not related to the level of metabolic activity. Cortex receives almost 90% of the blood flow, which is least metabolic active, and medulla receives only 10% of the blood flow, which is more metabolically active. The cortex has this luxury perfusion. The blood flow is 10 times what is needed for oxygen delivery, but this is required for perfusion to maintain the perfusion pressure at the cortex in the glomerulus. The medulla has barely blood flow, which is barely adequate to meet oxygen demands. Cortical blood flow is 500 ml per minute per 100 gram. Outer medulla blood flow is 100 ml per minute per gram, and the inner medulla blood flow is only 20 ml per minute per 100 gram. This is like rule of fives. This kidney receives 1/5 of cardiac output, 500 ml to each kidney, 500 ml per minute per 100 gram tissue, the cortex, and 1/5 of this, that is 100 ml to outer medulla, and 1/5 of that is 20 ml per minute per 100 gram tissue to the inner medulla.
Chital, just
Yes,
is there any justification? Because nothing happens randomly. I would also ask if you cannot answer this to Dr. Rushi also. Is there any justification of this peculiarity in blood flow, where you have a discrepancy, right? Where you have more metabolic activity, you have lesser blood flow, and then you have a luxury perfusion in the cortex. Is there any sort of advantage or some sort of that nature has devised it in such way? Because
sir, I feel the higher flow to the cortex, which is required to make the ultrafiltration easier and to maintain the filtration pressure at the glomerulus, while the blood flow at the medulla is very low, and in fact, which is very active metabolically. So that's the important part as a gray area of the kidney. Whenever there's ischemia, this part is exposed to ischemia.
To that extent, okay, we will discuss. I think once Rushiji is back into we will discuss.
Okay, sir.
Yeah, Arindam.
Hi, sir.
Hello.
Hi, sir.
Yeah, see, basically, it's a good question from your side. I don't think we know the exact answer. I'll tell you what we know. I don't think this is a perfection because the metabolically more active segment is getting less blood flow.
Yes, sir.
So definitely it is not perfection. But what I just feel that, nature always works in abundance. I mean, just to put things in perspective, if you make 1.8 liters of urine a day, 1800 ml of urine in a day, the glomerular filtrate generated is 100 times that amount. It is 180 liters.
Yes, sir.
Okay. So because of this extra abundance thing, you make urine 100 like ml of urine, and you work on it till only 1 ml goes out.
Right, sir.
So this is trying to achieve perfection at for everything that we need, whatever we can measure and what we can't measure today. So I think it has got more to do with that. But as far as the medulla is concerned, I'm sure that it is work in progress for nature, because it is definitely a compromised part of the kidney. Even though it is doing so much of work, it is getting less blood. And these are end arteries, so there is no collateral here.
Right, sir.
That's a huge problem there.
Okay, sir. Chalo, continue.
Okay, sir. Then we see the glomerulus and its function. The glomerulus acts as filter, which produces an ultrafiltrate of plasma from glomerular capillaries. The filtration is the bulk flow of solvent through a filter, carrying with it all the solids small enough to pass through the filters. The structure of this filter consists of the glomerular capillary endothelium, the glomerular basement membrane, and Bowman's epithelial cells, also called as podocytes. This capillary endothelium is highly specialized capillary endothelium, which has fenestrations, but it prevents cellular components of the blood to pass through. The glomerular basement membrane, which is made up of connective tissue and is negatively charged, and which acts as a main filter. The Bowman's epithelial cells, the epithelial cells with multiple projection called as Put processes, they maintain the basement membrane, and they have phagocyte function also. So this is the picture of glomerulus with endothelial cells, glomerular basement membrane, and the podocytes with in the lumen. This degree to which these solutes are filtered is dependent on two physical properties. That is the molecular weight of the solute. Less than 7,000 Daltons molecules, that will be freely filtered. Greater than 70,000 Daltons, the molecules are essentially not filtered at all. And in between 7,000 to 70,000 Daltons, the percentage of a given molecule that is filtered decreases with the increasing weight. The other dependent factor is electrical charge. The lower percentage of negative charge molecules will be filtered. The basement membrane itself has a negative charge, and the cellular components that they are not filtered during this filtration. The proteins in the plasma, the size and the negative, because of their size and the negative charge, they are not filtered in the system. The glomerular filtration rate depends on surface area of the filter, thickness of or permeability of the filter, the magnitude of any forces favoring filtration, and the magnitude of any forces opposing the filtration. That are the typical Starling forces. So glomerular filtration rate is coefficient of the filtration into forces favoring filtration minus forces opposing the filtration. That is glomerular hydrostatic pressure minus hydrostatic pressure in the Bowman's space minus glomerular capillary oncotic pressure and minus Bowman's space oncotic pressure. The GFR is in healthy kidney, it's 125 ml per minute, that is 180 liter per day. It means the entire plasma volume being filtered by the kidney 60 times a day. That is, and over 99% of this GFR is reabsorbed. The renal plasma flow is equal to renal blood flow into 1 minus hematocrit. That comes around 600 ml per minute. The filtration fraction is the GFR divided by renal plasma flow, which is approximately 20%. The regulation of the glomerular blood flow, it has two mechanisms: autoregulation and tubuloglomerular feedback. The autoregulation is considered with the myogenic theory, which this alteration in the afferent arterial blood flow rate alter the tension in the arterial wall. Increase in the afferent arterial blood flow, that increases glomerular blood flow, which increases arterial wall tension, which causes reflex constriction of afferent arteriole and increase in the resistance to blood flow, and which causes glomerular blood flow to come to normal. The tubuloglomerular feedback, if there's alteration in the glomerular filtration rate, the alteration in composition of the fluid delivered to the macula densa, macula densa senses these changes and acts to alter the afferent arteriole tone. The sympathetic nervous system, sympathetic nervous system activation causes vasoconstriction by noradrenaline. It causes greater constriction of efferent arteriole. The renin-angiotensin-aldosterone system, and this afferent arteriole granular cells in the juxtaglomerular apparatus secretes renin. The renin causes angiotensin 1 conversion to the angiotensin 2, which causes greater constriction of efferent arteriole. The stimulus for the renin is a decrease in the afferent arterial wall tension or sympathetic activity on granular cells caused by beta-1 receptors. The renal prostaglandins plays role in the autoregulation when the renal blood flow is compromised. Sympathetic system activation causes prostaglandin I2 release, which causes afferent arteriole dilatation. Atrial natriuretic peptide, which is secreted by cardiac atrial cells, they are released in response to atrial stage. It causes vasodilation of the afferent arteriole, causing increased renal blood flow. We need to understand some basic definitions before going ahead with the physiology of nephron other parts. The diffusion is a simple diffusion and facilitated diffusion. Simple diffusion is solutes with Brownian motion move from high concentration to low concentration. The facilitated diffusion in which the cell membrane proteins acts as a channel. Active transport requires energy to move solutes against the concentration gradient. The primary active transport pumps the solutes from low concentration to high concentration using ATP, while the secondary active transport uses the action of one solute moving and the second substance moving against the gradient. The paracellular and transcellular transports, this occurs across the epithelial cells and gaps between the cells. The co-transport and antipode, this happens during secondary active transport. Then proximal tubule, the proximal tubule has single layer of epithelial cells, which is packed with mitochondria. The luminal surface has brush border, and in between the cells are the tight junction. There are lateral intercellular spaces, which play important role in the reabsorption. Reabsorption, kidney receives 180 liter per day filtrate in the proximal convoluted tubule, in which 70% is reabsorbed, that is 127 liter per day. This PCT also secretes some substances into the lumen for excretion in the urine. In this sodium and bicarbonate, sodium bicarbonate, chloride, and water and the glucose are the major substances which are reabsorbed, and the secreted are the drug and drug metabolites and hydrogen ions. We'll see sodium absorption in the PCT. In the PCT cell, proximal tubule cells, this sodium potassium ATPase pump at the lateral space. This inside the cell has the negative charge, and it moves with the concentration and electrochemical gradient. With ATP use, three sodium ions are pulled out of the cell, while 2 potassium ions are taken inside. This causes decreased sodium concentration in the proximal convoluted tubule, which causes diffusion of sodium ions from the tubule lumen, and the potassium is permeable in the PCT cell. So potassium is again pushed out of the cell. This sodium, which is pumped out in the lateral space, which is diffused into the peritubular capillary. This is how the sodium is reabsorbed into the peritubular capillary. This reabsorption of the sodium is also coupled with bicarbonate, chloride, and glucose. And this potassium diffuses back into the lateral space. Then bicarbonate. The bicarbonate with this sodium potassium ATPase pump, as with the diffusion of facilitated diffusion of the sodium, which we have seen prior, sometimes the hydrogen is antiported to the tubular lumen. This hydrogen is combined with the bicarbonate ion in the tubular lumen, which forms carbonic acid, and this carbonic acid is divided into back into water and CO2 by carbonic anhydrase enzyme, which is present in the brush border or brush border of the proximal tubular cell. This CO2 is reabsorbed into the cell, and again with the reverse direction, this carbonic acid is again hydrolyzed to hydrogen and bicarbonate. Thus, this hydrogen is recycled while this bicarbonate is diffused back into the lateral space, and that is how this bicarbonate is reabsorbed into the peritubular capillary. Then chloride ions. The chloride ions are reabsorbed with two mechanisms. One is antiport mechanism with organic anions. The organic anions and hydrogen, they are reabsorbed and recycled into the cell. The sodium and bicarbonates ions are rapidly reabsorbed early in the PCT. That's why the concentration of the chloride ions left in the tubular lumen are higher, and this chloride ions, which are increased in the tubular lumen, they are reabsorbed by the paracellular diffusion into the cell. Then water. Epithelial cells of this PCT are very permeable to the water. This reduced tonicity of the fluid left behind in the lumen and increased tonicity in the lateral space due to this sodium potassium ATPase pump. This more ions concentration is there in the lateral space of the PCT comparative to tubular lumen. So this reduced tonicity in the lumen plus increased tonicity in the lateral space because of the ions. That's how the water is reabsorbed by osmosis via transcellular and paracellular routes. Then glucose. Glucose transport is coupled to sodium reabsorption. This sodium hydrogen ion exchanger at the tubular lumen side of the PCT. The sodium ion moves down the concentration gradient after this sodium potassium ATPase pump action. That time glucose moves against the concentration gradient. This dependent on the transport by specific carriers. So the maximum rate at which glucose can be reabsorbed is called as tubular maximum. If the plasma glucose is more than 10 millimole per liter, then tubular maximum will be surpassed, and then glucose will be found in the urine. The peritubular capillaries, they are continuation of efferent arterioles from same nephron glomerulus. They try low hydrostatic pressures and high oncotic pressures. The two sets of arterioles upstream and loss of water, but not the proteins. This favors reabsorption of water and electrolytes back into the plasma. The loop of Henle and vasa recta. This hypertonic environment in medulla causes the water reabsorption by osmosis, and that is how the concentrated urine is made. This alteration in the tubular fluid osmolarity isotonic to hypotonic. Descending limb is permeable to water while the ascending limb is impermeable to the water. There's large osmotic gradient between the tubular lumen and the medullary interstitium, which is called as countercurrent multiplication. The thick part of ascending limb has sodium potassium ATPase pump, which pumps out sodium out of the cell into the medullary interstitium, and it causes the concentration gradient. With this gradient, there's reabsorption of 1 sodium, 1 potassium, and 2 chloride ions via a specific transporter. Then descending limb. The descending limb of Henle is permeable to water and ions, which causes equilibration in the interstitium. The sodium and chloride diffuse into the descending limb. The osmotic gradient between it creates the osmotic gradient between the two limbs. At any levels, this osmotic gradient of 200 milliosmol per kg of water. The absolute values of osmolality within the lumen varies hugely up and down the medulla. This constant addition of ions from the ascending limb of loop of Henle to the descending limb and it causes increase in the tonicity till tip of the loop of Henle. The ascending limb tonicity decreases, trapping high solute concentration in medulla. The final osmolality of the medulla is caused by electrolytes and urea. Urea causes almost 50% contribution to high osmolality of the medulla. This urea diffuses down its concentration gradient into the descending limb, which causes high concentration in the tubular fluid. The collecting ducts, this reabsorb the under reabsorption is under influence of antidiuretic hormone. This makes medullary interstitial more hypertonic. The countercurrent exchange mechanism, there is specialized network of the blood vessels around the loop of Henle, which mirrors arrangement of loop of Henle. The descending limb of these vessels of vasa recta, the water is drawn out and the solutes enter to maintain the osmotic equilibrium. The ascending limb of vasa recta, water again re-enters and the solute leaves. This vessels also delivers nutrients, removes waste products like CO2 from the nephrons. The net result is to allow the blood to flow through the medulla without altering the osmotic gradient, which is created by loop of Henle. The distal tubule and the collecting ducts. The 180 liter per day of glomerular filtrate, among which 127 liter per day is reabsorbed in the TCT. The further 30 liter is reabsorbed in the descending limb of loop of Henle and still leaves the 23 liter per day to enter the distal tubules and collecting ducts. This reabsorption in the distal tubules and the collecting ducts depends on extracellular fluid volume and the osmolality. The maximum achievable osmolality of the medulla is reduced at the extremes of age. That's why the babies, young children, and elderly are more susceptible to dehydration. The distal tubule is impermeable to water, but some sodium and chloride can be reabsorbed. The collecting ducts are responsible for the concentration and the volume of the urine. These hormones acting on this collecting ducts for the reabsorption are ADH and aldosterone. The antidiuretic hormone and extracellular fluid osmolality. Collecting ducts only become permeable to water under the influence of ADH. ADH is secreted by hypothalamus. Then from the posterior pituitary, it comes into the bloodstream. It controls the retention or loss of water without electrolytes, that is free water. If extracellular fluid osmolality increases, there is increase in the antidiuretic hormone. This hormone binds to the receptors on the lateral surface on the collecting ducts and which causes increased production of aquaporins. The aquaporins are specialized protein channels which causes reabsorption of water by osmosis. This makes medullary part of the collecting duct permeable to the urea also, and which enters the medulla, making it hypertonic, which causes again maximum reabsorption of the water. If extracellular fluid osmolality decreases, the less urea and the less water are reabsorbed. The aldosterone and extracellular fluid volume. The aldosterone is produced by zona glomerulosa of the adrenal gland, which acts on cortical parts of collecting ducts. Aldosterone production is stimulated by rise in plasma potassium concentration and angiotensin II. If there is reduction in extracellular fluid volume like dehydration or hemorrhage, there's activation of sympathetic nervous system, which causes decreased blood flow through the afferent arterioles, which results in reduced glomerular filtration rate And this is sensed by macula densa, which secretes the renin and causes angiotensin 2 release, which increases sodium reabsorption in exchange for potassium and hydrogen ions. This increase in the extracellular fluid sodium content is ADH dependent water retention, which causes ADH dependent water retention and restoration of the extracellular fluid volume.
I think Rushiji like to comment. I'm very intrigued with the concept of the counter current, how accurate things that are developed. In fact, we have copied the similar things in our dialysis technology, right? To maintain a concentration gradient by the counter current flow. So Rushiji, some certain words of wisdom on the practical application of renal physiology. Mostly, yes, sir.
Yeah, thanks, Arinda. See, basically, very well done, Sheetal. I think you have covered a very difficult topic, and I think you included most of the points that are required in the discussion of these very difficult concepts. I feel that everybody who is attending should make an attempt to go find some time and read them up today while these things are fresh, so we all remember how they actually work. In terms of day-to-day application, the important things to remember are A, how will your kidney respond when you are dehydrated? And what would the practical application is? Suppose you have a pre-renal acute kidney injury. Why do you have a low urinary sodium? So that can be explained by everything that Sheetal just told us.
Yes, sir. Yes.
Similarly, when you speak of renal injury, then you know that there is a tubular injury, and once there is structural damage to the tubule, then your urine sodium goes up. Same can be spoken about fractional excretion of uric acid, which is a far better marker than sodium alone for volume changes. So, that can now be understood much better when you look at the handling of the salt and water in the kidney. The second important I wish to bring to everybody's attention is the tubuloglomerular feedback and the myogenic mechanism and the hormonal mechanism for maintaining the filtration fraction or the renal blood flow.
Sir, let me ask, sir, 1 minute. Let me ask Sheetal to go back to that slide. Sheetal, can you please?
Yes, sir.
So that it is easier for Rushiji to, if you can kindly go back.
Yes, sir. Yes.
This is the new.
Sir.
Take.
Sorry.
Don't have to hurry, please. I think it would be easier for Rushi.
Auto regulation. I just kept it very small, sir. I don't know. So
yeah, no worries. So basically, when we speak of afferent and efferent arterioles, and we speak about the different mechanisms, the ones which can be altered pharmacologically are basically related either to the prostaglandin mechanism or to the angiotensin 2 mechanism.
Right, sir.
So that is why, if your body is trying to maintain the renal blood flow effectively by dilatation at the level of the afferent arteriole and vasoconstriction at the level of the efferent arterioles, then these are the patients who must never be exposed to drugs that either block prostaglandins or which have any negative mechanism on the angiotensin 2. So if you add an angiotensin receptor blocker or you add an NSAID at this point to this patient, they'll end up with a frank AKI. So it's very important, if we understand renal physiology, then we understand that to prevent kidney injury, which are the patients where we should not be using such drugs. Correct?
Fair enough.
yes, sir.
Yeah. So similarly, these are good days, but all these drugs, now we should add the other drug, DAPA, the SGLT2 to this list. When we say NSAIDs and ARBs, we should be adding diuretics and SGLT2 to the list, because these are the drugs which, when renal autoregulation is active, we should try and avoid these drugs. So we know renal autoregulation is a natural mechanism to maintain renal blood flow in case of volume depletion.
Sir, we have planned a class, I think at least a couple of classes where we will ask our nephrology friends to also guide us amongst the very precise pathophysiology, because I wanted a very clear backdrop of understanding of renal physiology, so our critical care friends can understand when we
Correct.
go into the individual drug physiology, that how it affects, how the diuretics are working, how it is
So
affecting the
actually,
physiology.
Arindam,
Yes, sir.
handling of acid base and electrolytes in the kidney is something which we have touched very superficially today, honestly.
No, this is just a, sir, this is just a beginning, sir. I didn't want to burden, because it would have been very, I specifically asked Sheetal to just, it's a, I would say a curtain raiser to that extent. So we have 52 classes in the entire whole year. So we'll deal with it in detail, sir. But
I
specifically
also
in
feel,
domain.
Arindam, I also feel that if we could put up the index for the 52 classes up for the people
Sir,
who are
I will,
regularly
I'm
attending.
working on it, sir. I'm waiting
Yeah,
for
because
certain
once we have the
feedbacks.
scope of the, once we have a scope of this kind of a thing, then we know exactly what we are going to discuss on a given day.
Fair
So
enough.
we don't cross over also, and we don't miss out also on
And
anything.
I would request to all the listeners or the people who have joined today's classes, you can please suggest some of the topics that you need or you think should be included in this discussion, which we'll have in 52 classes. So if we take two different topics, so we will have around 100 classes or 100 topics to be covered. So kindly please suggest, because some of the things can be very important, which I may have missed on that year. Yes, Tushar wants to say something.
No, typically, I think so. Last time also, when we have started most of with anatomy, physiology, and everything else. This is a kind of syllabus we are setting in. Am I correct?
To some extent, yes.
To some extent, there is a syllabus which we are setting in, and we probably need to see that if there is a syllabus, there has to be a certain part which is I would, if I divide 1 year into three different segments or four different segments, probably first segment, second segment, third segment, and fourth segment can be divided according to applied anatomy, physiology, or whatever composition we are thinking of in that direction, and that may remain almost same for almost all years. The content may change, but
Uh,
the heading remain the same.
the additional complexity, Tushar, is that there are people, almost 90% of the people are not into any curriculum. They are giving their valuable time joining to learn certain anecdotes, right? So we have to entertain those audience also. So we have to make a mix of something of the syllabus and something which is offbeat. So if you see, I'm trying to mix certain things, one which is according to the syllabus, and the other topic which I can say would be attractive, crowd pulling. That's how we are selecting. So definitely I will discuss with you and take Rushiji's and Dasa's guidance, and then we will try to make a complete go ahead syllabus. But I would be very happy that if you please in the group write whatever you want to be in this curriculum.
Sure.
Sir, should we proceed, sir? The Alok has, I think hopefully Alok has joined. Alok, are you?
Yeah, yeah, sure. Let's go
Yes,
to the next part.
Okay, so
So,
Alok, you can share your screen. You can Sheetal, you can thank you.
Yes.
Sir, I think we are getting good attendance from certain other corners of Mumbai, outside Mumbai also. But we will try to include people from different areas. So please feel free. This is a free class. This is we want more people to come in and more insights and wisdoms to be shared. So Alok Mishra, who is has joined RFH Reliance Foundation Hospital very recently. He is a fresh DRNB in nephrology. He has joined Dr. Rushi Deshpande's team, and he is obviously he would have very I would have said that new knowledge and acquired knowledge to be shared. But nonetheless, we have other senior nephrologists to share their experience with it. Alok, all yours.
thank you, sir. Thank you so much. Good evening to everyone. So today I'll be covering something uncommon, which we as a nephrologist see very commonly, but for other people, it might be some atypical cases. So it will be more of a case-based pattern, not the typical theoretical class. And I'll be covering something about that topic. So as we know, acute kidney injury, one of the most common clinical problems associated with increase in the morbidity and mortality in ICU. We know uh, uh, almost between 20 to 50% cases will have AKI. And definition, we have discussed it in last 2-3 classes as per KDIGO, that is increase in the creatinine levels at least by 0.3 within 48 hours or 1.4 time baseline, which can be known or presumed to be occurred within last 7 days. And as urine output criteria being less than 0.5 ml per kg per hour for at least 6 hours. So incidence of in-hospital and community acquired AKI has been increasing, which we are seeing. It remains the risk factor for long-term renal complications, and even partial renal recovery following AKI leads to progression of CKD. So I will I have 3 cases, so I'll discuss those. So we'll have some interesting case scenario in which we have seen AKI cases. So there is a 25-year-old male who presented in ER with complaints of a fever with chills, cola-colored urine for 8 days, and followed by oliguria. On further inquiry, patient had a similar history of illness 2 years back also, where he had hemolysis, but that time it was self-recovered, non-dialysis dependent. This time on examination, patient had pallor, edema, but patient was normotensive. Seeing labs, it was a pancytopenia, hemoglobin big 6 grams, TLC 2,300, platelets 30,000, retic count 3.4%. On PS, there was no hemolysis sign like cystocytes. LDH, CPK, G6PD, Coombs test, all were negative. Procal was normal, so there was not much infectious part. Urine was dark brown reddish color, and there was heme plus on dipstick and RBC plus, which suggests hemoglobin complements were done.
Alok, I'm interrupting. So
Yeah.
before you give away the A, I would ask you to ask the audience regarding their response or their guesses, right?
Okay.
Before you give away the diagnosis.
Okay, sir.
Thanks.
So this complements level, when I'll just finish those investigations so we can open discussion.
Yes.
Complements were normal, ANA was negative, and USG did not show any thrombosis or occlusion. So we have a AKI in young patient, no infection, no infectious events, but there is pallor, there is edema, BP is normal, dark color urine, other things are, other parameters were fine. So what do you feel? What could be a etiology for AKI?
And this is also recurrent, right? It has.
This was a second episode.
Second episode.
Yes.
So we are expecting some plausible answers from the participants. Hemraj, you are there. Edwin, I think.
So this
Tejas,
could be
yes.
glomerulonephritis, like post-streptococcal, like they can present like this.
So you are saying glomerulonephritis.
But usually glomerulonephritis will have proteinuria also, which was absent here.
There is no
And patient was normotensive, and there was no history of any infection. There's no, basically, there was fever, but we did not have any other evidence.
But normotensive with no proteinuria almost completely rules out glomerulonephritis. Don't you think so, Alok?
Correct.
Okay, so almost rules out. Anyone else? Dr.
Sir, can it be malaria, sir?
Rohan, malaria without fever. And
Fever
recurrent
tha na, sir. There is a history
recurrent
of...
malaria in 2 months.
viral myositis.
Niranjan is saying viral myositis. Was there any history of fever?
There was history of fever with chills and cola-colored urine.
Okay, for 8 days. So,
Yes.
and also with pancytopenia, which could be in certain, well, like parvovirus and others, right?
Possibility, yes.
But there are nothing.
I think no hemolytic feature.
No hemolysis. Now I'm coming to that. No rise in LDH or CPK.
Yes.
Right. So that rules out your myositis. Don't you think so, Niranjan?
Yes, sir.
So that doesn't fit in. Looks like so that doesn't fit in. Okay, anyone else? Narendra is online. Advait is there. Vikas. Come on, quick answer.
Sir, I couldn't hear the question. If you could repeat it.
Santo. Now we are asking for a young guy with an 8 days of history of fever with chills with cola color urine, which gives you pancytopenia, no proteinuria, no normotency, LDH, CPK, G6PD combs, all normal, no hemolysis or cystocytes, normal procal. Next slide, please. Then you have just an hemoglobinuria with the normal complements, no ANA normal, and there is no thrombosis or occlusion in the USG. So what could be your A? Hus TTP, you're ruled out. Hus particularly ruled out, Santosh, because there are no, your cystocytes are on the normal and non others. Okay, I think Dheeraj is going to answer that. Yes, yeah, you are almost A. Ajay, you are the senior most Dheeraj you have.
HLH, secondary to viral infection.
HLH is a distant possibility. You could have asked for a triglyceride or ferritin.
Ferritin level we don't have.
But does HLH normally have a hemoglobinuria?
No, sir. Pancytopenia and kidney involvement is likely.
Okay, I will ask Dr. Dheeraj to speak, please.
Nothing. I just think this. I just was waiting for the juniors to answer. But the thing is, only little unusual is the hemolytic picture. Otherwise, this strong hemolysis also can lead to hemoglobinuria, which everybody knows. In this case, maybe the hemolysis might have occurred quite earlier, and now active hemolysis is not going on. And there's a pancytopenia picture, which is a plastic-like picture we get in PNH. And all other, I think, autoimmune marker, fever, and other things. Schistocytes, everything, all this negative. I just was waiting for others to answer, but
obviously, you would be the last one to answer once our junior people tries it. Alok, let's unveil.
Yeah. So, sir is correct. So, we involved hematologist. Bone marrow was done, though it was not cellular marrow with erythroid hyperplasia and normal, near normal morphology. So, flow cytometry panel was sent and it showed PNH clones. So this was basically AKI, Kedigo stage 3 secondary to PNH. There was a past history of recurrent AKI which did not require any dialysis support. And here there was a possibility of intravascular hemolysis was kept. This patient was managed basically conservatively with blood transfusion. Initially, then patient required RRT because of oliguria fluid overload status. Glucocorticoid trial was given almost 1 mg per kg for 4 weeks, and after 4 weeks there was good recovery. There was clinical and biochemical improvement.
Alok, what are the? Sorry, you are answering this. Please go ahead. I was asking that.
Correct. So these acute hemolytic episodes in PNH can be precipitated by infections, exercise, which most of the people could guess that those could be a precipitating cause like infections, exercises, transfusion, reaction to drugs, immunization, surgery, usually most commonly seen with gastroenteritis. But very important thing is it can be also happen without infection. And nephrologically, if you biopsy such patient, we'll see ATN-like picture with hemosiderin deposit. Usually hemosiderin is seen on Prussian blue stain as a blue color And what was the mechanism? So one is a toxicity of both stromal and free hemoglobin to the renal tubules. This can lead to intrarenal vasoconstriction due to pigment scavenging the vasodilator NO in the renal microcirculation. Also, like pigment nephropathy, it can cause intratubular obstruction, and very rarely bilateral renal vein or artery thrombosis. So those could be the possible mechanism which can is seen in PNH. In India, there was only one paper from South where they had almost 14 patients of PNH, out of which they had seen AKI, where 6 patients had required renal replacement therapy. Other 8 patients were just had supportive treatment and they recovered well. Only 2 patients, they expired because of the sepsis. Otherwise, the recovery was fine in that paper.
Alok, any long-term prophylaxis required, or this is only whenever we have to?
No,
You said
basically, we
steroids
just
for
have
4
to,
weeks.
once that was what they tried. Eculizumab definitely is not available with us that commonly. Usually, Western world they use quite a lot. We don't use, but these patients were managed with steroid and just dialysis.
Okay.
Yes.
So I think prize goes to Dheeraj. You will have an A, but you being a senior physician and a faculty, so it's a virtual prize. So on that part.
I
Rushi,
just wanted to comment,
Yes,
eculizumab,
please.
I agree it's not available. Otherwise, that would be the best. And the mechanism is just complements. These RBCs are lacking the CD55-59 antigen on their cell surfaces. So that's why the complement have a free hand and attack these RBCs, even the pre-genitor or cells. So that's why the bone marrow production is also affected and RBC hemolysis also occur. So we have to save these RBCs and these pre-genitor cells from the complements, and that's why eculizumab is nothing but that complement attack complex that is, I think, this C5 anti-C5 mechanism. So this is the way. Steroids, of course, it will reduce the complements also, other things also. This is the way, but that is the middle way out. And last option, rarely transplant also can be done. Transplant may not be that successful in PNH, but that is the option because you cannot continue giving steroids. You know, all of you all know the problem with steroid, and there can be sudden hemolysis, infective episode, other thing, and there can be problem like Dr. Alok, who's the presenter, pointed
Dr.
out.
Alok.
A couple of patients with sepsis died. So this, I think, we accept in India, but outside they would not accept when we have options or better options. But I agree, right now, steroids and blood transfusion, and if the patient can import eculizumab, that medicine to prevent the complement from attacking. And lastly, you can consider bone marrow transplant.
Fair enough. Alok, do you have any other case?
Yeah, I have, sir, 2 more cases.
Okay, please.
So 54-year-old female without any comorbidity came with decrease in appetite and nausea for 7 days, no history of any systemic involvement, no clinical evidence of infection, non-oligouric, normotensive, normal sugars. Creatinine in the OPD found out to be 3.8 mg%. Urine sediment was bland initially. LFT normal, CBC was normal except some eosinophilia. USG was normal, no organomegaly or lymphadenopathy. Later, urine had some sterile pyuria and proteinuria on follow-up found to be tubular range 800 mg. ANA, immunoblot, ANCA were done, which was normal. And because of unexplained AKI, renal biopsy was done. So renal biopsy showed acute interstitial nephritis and there was no granuloma. So the question was, what was the etiology here? So here we had ruled out infection. We had ruled out other possibility of AIN. So should we continue or should we discuss it here only?
I think let's ask people to give some certain differentials. Yes, please, guys. Akhil is asking for drug history. Yes. Medication history. Alok, any history on the medication?
There was only patient was taking Pantocid for last 3-4 weeks. Pantoprazole.
Pantoprazole only. Avni, you want to? Chandrima, you would like to ask anything or comment? Only pantoprazole, because I was also tempted to look into and drug in acute interstitial nephritis is many of the times are related to a lot of drugs, particularly our commonly used antibiotics and others. Okay, so any more comments, any more guesses, any guidance? Niranjan is asking for eosinophils in where? In urine? PPI known to cause AIN. We'll come to that. PPIs are actually being also implicated for certain many things. Akhil, I would ask you to be a little more patient. Niranjan is asking for eosinophiluria. So let's go ahead and see. Alok, you can proceed.
So basically, eosinophilia usually it is done by either Hensel cells or this right cell, but the sensitivity is very low, less than 10%, hardly 1 in 100.
And also not many. I have seen the labs to report also eosinophilia.
Yes,
That
very
is
true.
also a difficulty.
Very true, sir. So it is not done commonly, though it is called very specific, but it is very less sensitive, less than 10% of sensitivity. So most of the people have guessed it correctly. There was no infective or autoimmune cause. History was taking Pantocid twice daily for 3 to 4 weeks. So it was diagnosed as acute interstitial nephritis secondary to PPI only. PPI was stopped, and within 2 to 3 weeks, renal function recovered to normal. Some people use a steroid also 1 mg per kg for 6 weeks and see. But once if you have a cause, then a lot of time you don't use steroid and just stop the causative medications.
Alok, I have a question for you.
Yes.
How do you know this was PPI induced AIN?
Sir, because other infection related and autoimmune workup was negative. So that's how that was by ruling out.
I think PPI induced AIN is not so common.
Yes.
Number one. Number two, here essentially it's a diagnosis of exclusion.
Correct.
Now, if I was to ask you, how will you confirm that this was PPI induced AIN? How can you do that?
One thing, we had stopped and saw the response. So
well, it could be anything else that was stopped at the same time that we don't know about.
Yes.
How do you know? How can you confirm? Is there any way in the world you can confirm that this was PPI induced AIN?
But I'm not very sure.
Anybody else? How can he confirm? It's like the Cox postulates. Which is the last one in the Cox postulates in infection? Rechallenge. So if you rechallenge or the patient accidentally takes a PPI again and gets it, then for sure you can say this. Because here an AIN is essentially a hypersensitivity like a reaction.
Correct.
It's like a classic type 3 or previously what used to be called as serum sickness. So that is the kind of presentation you get, where you get hypocomplementemia, you get eosinophiluria. So these are all reactions which is like an old classification of immunity based things is type 3.
Correct.
And then that rechallenge is one of the fundamental things which you can tell you that yes, it was necessarily the same agent that you are labeling as etiologically responsible for the AIN. There's no other way for you to be sure that this is PPI induced AIN. All that you can say is you have a patient with an unexplained AKI, which turned out to be an AIN, which resolved after withdrawal of PPI and time. So we know that a lot of things, a lot of times you can have an AIN without exactly knowing the etiology, and it just gets better with time.
Correct.
Sir, what are the other A? Are you going to show, Alok?
Yes, sir. There is
Common implicators? Yeah, please.
so most commonly seen is drugs in various studies, almost 60 to 75% chances are being with drugs where antibiotics like ampicillin, cephalosporins, ciprofloxacin, cloxacillin, methicillin, penicillin, rifampicin, sulfonamide, vancomycins are there. NSAIDs are there. Other drugs like allopurinol, acyclovir, famotidine, furosemide, omeprazole, phenytoin. All these drugs have been seen associated with AIN. Infections, almost 5 to 10% infections where bacterial like Brucella, Campylobacter, E. coli, Legionella, Salmonella, Streptococcus, Staph, viruses like CMV, EBV, hantavirus, HIVs, and other organisms like lepto, TB, Mycoplasma, Rickettsia, Schistosoma. All these are seen associated with AIN. Idiopathically with anti-TBM, that is tubular basement membrane, and TINO, that is tubulointerstitial nephritis with uveitis syndrome. And sometimes it is also seen with associated with systemic diseases like sarcoid, Sjogren's, or SLEs.
Fair enough. I think this was a good one. Let's move to the last one. Last A.
So case 3 is 42-year-old male.
Arindam, sorry,
Yeah, sir.
before
Sir.
Alok goes there, can I just make a statement here?
Please, sir, it's your platform.
No. So with your permission, see, basically what happens in an AI, and what's important for all the people to remember here, just my own take home on this, is when you do a biopsy and you see an interstitial nephritis, it is not telling you the etiology.
Correct.
Okay. When a biopsy is done and you see an interstitial nephritis, the first question you should ask is it acute interstitial nephritis or is it a chronic injury? These two can be seen very separately on the biopsy. So whenever you are calling as AIN, you are talking about acute interstitial nephritis. You should not see any signs of chronicity on that biopsy. Okay. If you're going to call it as an AKI related to AIN, number one. Number two, the word itself is allergic. Allergic acute interstitial nephritis. So the other important thing that we see here is eosinophils in the interstitium. And that is frequently something that tells us presence of more polymorphonuclears and eosinophils in the interstitium is suggestive that your AIN is of an allergic etiology. And also it portends a better prognosis in the long run. Because a lot of times, this is like a wastebasket diagnosis. You see a biopsy, it says some interstitial nephritis, but that's not etiologically going to tell you what it is.
Yes.
Sure. Carry on, Alok.
So we had a 42-year-old male with generalized weakness, low-grade fever, diffuse myalgia for 2 days, history of chronic alcoholism, no any history of upper GI bleed or PR bleed, any drug or severe malnutrition, no any history of seizure disorder, any drugs, palpitation, syncope, or any altered bowel habits, no clinical evidence of chronic liver disease or dehydration. BP was in normal range, no edema, no pallor. So on labs, creatinine was 4.4 mg, urine was bland, no sediments, CBC was normal, no anemia, thrombocytopenia, mild transaminitis with SGOT being 90, SGPT 124, bilirubin 1.02. In electrolytes, sodium was 132, potassium was 2.6, chloride 102, magnesium was 1.3, calcium 8.9, phosphorus 4.2. So hypokalemia, hypomagnesemia was there. CPK LDH was normal. ECG had shown hypokalemic features like ST depression, and U-wave USG was normal size kidney, and there was no any CLD feature. Yeah. So that was a story.
Can you go to the first slide, the history wala slide? Nah. 42 male, generalized weakness, low grade fever, myalgia for 2 days. History of chronic alcoholism. No past history of upper GI drugs and others. So, yeah, is this a severe malnutrition there or no history of malnutrition?
No history, no history.
No history of malnutrition. And then next page, I'm just revising the next page. There is no history of drugs, seizure disorder, palpitation, syncopes or altered bowel habits. You have given enough good clues. Not evidence of CLD. It is also evident in the USG, normotensive, and no edema, no pallor. So only findings are next slide. High creatinine, no active sediments, CBC normal, only a transaminitis. So there is considerable hypomagnesemia and hypokalemia, which is also evident in the ECG with a normal CPK. Okay, guys, Vikrant wants to know that is there anything in the ABG? Okay, we can understand, Vikrant. What are you thinking? Without ABG, what is your good guess? If you please say so. You can unmute and speak, please.
Sir, possibility of RTA or
Which type of RTA, which day, and why you are thinking of renal tubular acidosis? Anyone else?
there is significant hypokalemia without any history of obvious potassium loss.
Okay, and that also explains your little bit of myalgia, right?
Yes, sir.
Okay, anyone else? Any more comment? Santosh, Pritima has joined. Anyone else? Okay, so let's go to the next slide and see whether Vikrant is.
So ABG was essentially normal. Here, diagnosis of AKI was secondary to hypokalemia. This hypokalemia was secondary to hypomagnesemia because patient being alcoholic, intake was poor. Though patient was not malnourished, but intake was poor. So there was hypomagnesemia and hypokalemia. So that has led to AKI. There was correction of this magnesium and potassium, and over 2 to 3 weeks, even the renal function came down to 1.2 mg per dl. So why this has happened? So pathophysiology behind that was hypokalemia usually stimulates the production of vasoactive mediators, which results in the increased vasoconstrictor stimuli, that is endothelin 1, thromboxane B2, angiotensin converting enzyme, and angiotensin 2. And it reduced the vasodilatory mediators like prostaglandin E2 and endothelin-derived relaxin factor. So basically, there was more of a afferent vasoconstriction, which led to AKI-like situation. Also, it is seen that even hyperkalemia also can, this was acute case. In chronic cases, what we see even chronic hypokalemia also can lead to CKD, where usually on biopsy, we see some isovolumetric vacuoles in the proximal tubules. And that is also one of the causes for CKD if it is not corrected properly and adequately. Apart from that, even hyperkalemia also is known to cause AKI. Most of in situation if there is some obstruction distally, so it increases the tubular pressure, which disrupts the high resistant nature of the distal nephron, which leads to loss of electrical driving force of K secretion. And also, if there is sudden reduction of GFR, so this K secretion becomes limiting factor. So this hyperkalemia also can lead to acute kidney injury, basically causing some tubular damage. So,
Alok,
yes, sir.
are you sure about what you're saying?
That was a case that was like Hello.
Yeah, sorry, I couldn't hear you.
So that is was like suspected in this case.
No, Alok, I think you know what? I think we are missing the point here. How many hypokalemias have we seen in the last 1 week, and how many of them had an AKI? See, hypokalemia induced AKI is an extremely rare diagnosis.
Correct, sir.
Similarly, hyperkalemia in the setting that you described is not the cause of the AKI, it is a result of the AKI.
Yes.
Your inability to secrete potassium in the distal tubule was because of inability. It's all that distal RTS that you describe. That's what you were describing when you said of distal obstruction with the hyperkalemia.
Correct.
So that does not mean that the hyperkalemia caused the AKI. The distal obstruction caused the AKI in the hyperkalemic scenario. In the hypokalemic scenario, what you spoke about chronic kidney is correct. Persistent hypokalemia is known to cause microcysts in the kidney. It can cause tubular cyst and tubular vacuolization and cause chronic tubular injury. Yes, that is absolutely true. But in terms of hypokalemia, acute hypokalemia itself being the cause of AKI with complete reversibility in 7 days, I think it's an extremely rare and uncommon scenario. I don't want people in the audience here going out and labeling hypokalemia as the cause of AKI to their patients from tomorrow. Please remember, this is an extremely rare setting that he's describing. Okay, hypokalemia is usually the result, and this kind of a scenario where you have hypomagnesemia and hypokalemia with an AKI is more likely a scenario for proximal tubular injury, where, like you described in the first part with Chetal's lecture, we know that 70% of the reabsorption is happening there. So some problem with absorption because of tubular injury leads to an AKI. So again, if I was to say, I would more likely bet my money on a fact like a tubular injury which responded in 7 days to conservative treatment.
Yes.
Rather than calling it an hypokalemic AKI. I mean, not that it has not been described in literature, and whatever Alok spoke about the changes at the level of afferent and efferent arterioles have been described in animal models. But honestly, I think this is a very rare thing in clinical practice, day-to-day practice. And I really don't want anybody in the audience to start labeling hypokalemia as the cause of AKI from tomorrow. Sorry, Alok, but I think it's very important to point out that this is an uncommon scenario, and we really don't want, our friends here to go home thinking that hypokalemia itself can be labeled as a cause of AKI in clinical practice.
Very
Can it be contributory, sir? Because this profile of patients we are full of this profile of patient from our hepatology stream. So we get a lot of malnourished.
We see a lot of actually, Arindam, you get more of these people from the oncology stream because they are the ones who use agents commonly leading to proximal tubular injury. And we see a significant proportion of persistent hypokalemias, which we are managing in practice. And likely for magnesium as well. Like I said, in animal models, it has been described that severe hypokalemia can lead to vascular changes at the level of afferent and efferent arteriole, leading to a predisposition to AKIs and also uncommonly precipitate an AKI. That being said, much more commoner mechanisms of hypokalemic AKI would be hypokalemia with myopathy, hypokalemia with raised CPK, hypokalemic paralysis, which we have seen. Those would be far more commoner presentations with hypokalemia rather than a pure AKI with no other findings. Also, this particular patient, this 42-year-old young chronic alcoholic who was described with hypokalemia, one of the presentation things on the first slide said that the patient had severe myalgia, which was, I feel, a part of the hypokalemia. And it would be important in this patient to know the CPK, whether it was elevated with the hypokalemia, hypomagnesemia, and muscle pain that the patient had. Because see, hypokalemic AKI with a non-oliguric AKI is very uncommon. Hypokalemic AKI would be a hemodynamic injury and would normally present with oliguria. If there is no oliguria, I would bet my money on proximal tubular injury.
Yes.
Fair enough, sir.
Yes.
Fair enough. So we can conclude today's session, sir, with Rishiji's permission. And I would thank both the speakers, Sheetal and Alok. And I would also request you guys to volunteer. Thank you. Good night.